Did you know chlamydia is the most commonly diagnosed STI right here in the UK?
Hmm.
And what's really striking, honestly, is that a huge number of cases are just silent.
Completely silent, yeah.
Makes you think, doesn't it? Welcome to the deep dive. So this time we're tackling chlamydia head on. Think of this as your high-yield revision session,
Yeah.
all the key info you need to really get a grip on this infection fast.
Exactly, a focused look at the essentials.
Our goal today is basically to break down everything you need to know, starting from the definition right through to what happens if it's missed.
Which is crucial given how often it is missed.
Exactly, because so many men, maybe half, and wow, up to 70% of women have absolutely no symptoms. So understanding this silent threat is just vital.
Couldn't agree more.
Okay, so let's map it out. We'll cover what it is, the causes, who's at risk, how it actually affects the body.
What else it might look like.
Right, the differentials, then how common it is, the signs, if any, how we test for it, treatment, the outlook, and of course the complications. Ready to dive in?
Let's do it. Okay, so starting with the definition. Chlamydia, it's a really, really common STI. It's caused by a bacterium, Chlamydia trachomatis.
Okay.
And it hits both men and women, its main target, usually the genital tract.
Yeah.
But, and this is important, it can also show up in the rectum, the throat, even the eyes.
Right. Now, you sometimes hear chlamydial genital infection. Is that different from just chlamydia?
Ah, good question. So chlamydia is the kind of umbrella term for any infection from Chlamydia trachomatis.
Gotcha.
When we say chlamydiogenital infection, we're zeroing in on the sexually transmitted type affecting the genitals. It's specific strains, you see, of the same bug that prefer those areas.
Sure.
Interestingly, other strains cause different things, like trachoma, that's an eye infection,
Yeah.
but same family of bacteria.
So different versions cause different problems.
Mhm.
Makes sense.
Exactly. But for today, for this revision focus, we're mainly talking about that genital infection, which, like you said, is the #1 diagnosed STI in the UK.
Which really underlines why we need to know about it. And it's not just a UK problem, is it?
Oh, definitely not. Globally,
Yeah.
it's a major preventable cause of infertility. And that links back to what you said about it being silent.
Right.
The fact it's so often asymptomatic. 50% of men, 70% of women, no clue. That's a huge part of why it spreads so easily and, well, why it can lead to serious long-term issues if it isn't treated.
And those issues, the sequelae, they're pretty serious. We're talking pelvic inflammatory disease, PID, ectopic pregnancies, infertility, proctitis, even epididymitis in men.
Yeah, not things you want to ignore.
Definitely not.
Yeah.
So understanding how it gets started, etiology is key. What causes it? How does it spread?
Simple cause,
Mm-hmm.
the bacterium, Chlamydia trachomatis. Transmission, primarily sexual contact, so vaginal, anal, oral sex with someone who's infected.
Okay.
Basically, the bacteria are present in genital fluids. So any sexual activity involving those fluids can pass it on.
And you mentioned vertical transmission, too, mother to baby.
Exactly. That can happen during childbirth.
Wow.
If the mother has an active infection, the baby can get infected passing through the birth canal.
Leading to...
Usually conjunctivitis, an eye infection, or sometimes pneumonia in the newborn.
Okay, so we've got the what and the how. Now, who's most at risk? Let's unpack the risk factors.
Yeah, so generally the risk factors look pretty similar to other STIs. Unprotected sex is a big one, so not using condoms.
Right.
Having multiple sexual partners or a history of previous STIs, that all bumps up the risk. And we definitely see higher rates in adolescents and young adults.
Why is that, do you think?
Probably a mix of things. Behavioral factors, maybe biological susceptibility too. There's that mnemonic, which might help you remember. Young, multiple unprotected partner history, think YMUPH. Youth, multiple partners, unprotected sex, partner history.
YMUPH. Okay, useful. And the notes mentioned more specific factors for the genital infection.
Yes, drilling down a bit, being under 25 is a major one. Statistically, that's the highest risk group.
Okay.
Having a partner who you know has chlamydia, obviously. Multiple partners in the last year or a recent change in partner that increases exposure risk.
Makes sense.
Inconsistent condom use is key.
Yeah.
And relying only on non-barrier contraception, like the pill, doesn't protect against STIs.
Right.
Having other STIs can sometimes indicate you're in a higher risk network. And interestingly, there are links suggested with lower socioeconomic status, perhaps related to access to care or education.
And you mentioned something about vaginal microbiota.
Yeah, that's quite fascinating. Ongoing research is looking at whether the natural balance of bacteria in the vagina might actually influence how susceptible someone is to picking up the infection. Still more to learn there, though.
Really interesting stuff. Okay, so the bacterium gets in. What does it actually do? Let's get into the pathophysiology. How does it cause the damage?
Okay, so Chlamydia trachomatis is what we call an obligate intracellular bacterium. Fancy term. Basically means it has to get inside our own cells to survive and multiply.
Like a little invader.
Exactly. It particularly likes the cells lining mucous membranes, genital tract, rectum, throat, eyes, as we said. Once it's inside, it starts replicating. And this whole process triggers inflammation and causes damage to those reproductive tissues.
And it's that inflammation that spirals into the bigger problems like PID.
Precisely. In women, the inflammation can track upwards, leading to pelvic inflammatory disease, PID. A way to remember PID. Painful infection descending. Although it's ascending, the pain descends.
Huh. Okay, I'll remember that. And for men?
A key one is epididymitis, inflammation of the epididymis, the tube carrying sperm. And sometimes, though less common with just genital infection, it can spread via the bloodstream or lymphatics.
Okay, so if someone comes in with symptoms that could be chlamydia, what else should be on the radar? The differential diagnosis.
Yeah, this is super important for getting it right. The symptoms discharge, pain urinating, they could look like a lot of other things, other STIs, other infections.
So you can't just guess based on symptoms.
Absolutely not. Lab tests are essential. And critically, if you're thinking chlamydia, you should probably be testing for other common STIs too, because co-infections aren't unusual at all.
Okay, so what are the main things to differentiate it from?
Gonorrhea is a big one. They often travel together. You could think clagon as frequent partners in crime.
Plug on. Got it.
In men with testicular pain, you'd also think about other causes of prostatitis or epididymal orchitis. For women with pelvic pain, possibilities include trichomonas vaginalis, UTIs, bacterial vaginosis,
All right.
even non-infectious things like endometriosis, or maybe a forgotten tampon or something, a urethral or vaginal foreign body. Occasionally, a periurethral abscess.
Okay, quite a list. Definitely highlights why testing is non-negotiable. Let's zoom out again, epidemiology. How common is this, really?
Very common. As we said, most diagnosed STI in the UK particularly hits sexually active young people. 15 to 24-year-olds have the highest rates.
Any specific stats?
The notes mention about 1 in 10 young women in the UK having it. That's pretty significant.
Wow. And the numbers have been going up?
Well, the reported numbers have, yes. But that's largely thought to be because we're doing more testing, better screening. We're just finding more of it, especially the asymptomatic cases.
Right, better detection.
Globally, the WHO estimates, get this, 131 million new cases every year, worldwide. And most are silent.
Astounding. What about England specifically?
The 2019 data showed around 229,000 new diagnoses in England. And yeah, about 60% of those were in the 15-24 age group.
No, it dominates that age bracket.
It really does. Chlamydia made up nearly 46% of all new STI diagnoses that year. There was a slight dip noted, maybe linked to less screening in 2020, but the overall picture is high prevalence.
Okay. So despite being so common, it often hides. What are the clinical features, the actual signs and symptoms people might get?
Yeah, got to keep stressing the asymptomatic part, 70% women, 50% men roughly. But when symptoms do show up, they can vary. Abnormal discharge is common from the vagina or penis.
Okay.
Pain or burning when peeing, that's dysuria. Lower abdominal pain sometimes. Pain during sex, dyspareunia, you could maybe remember the Ds. Discharge, dysuria, discomfort, abdominal or sexual.
Discharge, dysuria, discomfort, useful. And it's not always just genital.
Correct. If the rectum's involved, maybe from anal sex, you can get proctitis, rectal pain, discharge, bleeding. If the throat's infected via oral sex, pharyngitis is possible. But again, often no symptoms there either.
What might a doctor or nurse actually see during an examination? Specific signs.
In women, you might see signs of cervicitis, an inflamed cervix, maybe red, swollen, perhaps with discharge, or it might bleed easily when touched. They might report the dysuria. On exam, you might find tenderness in the abdomen or around the ovaries and tubes, adnexal tenderness.
And in men?
Common things they report are urethral discharge and dysuria. On examination, you might find tenderness in the epididymis, see the discharge, or they might describe a feeling of fullness down there in the perineum.
Okay. So if someone has symptoms or fits a risk profile, how do we actually confirm it's chlamydia investigations?
Right. Diagnosis hinges on lab testing. You need to get samples from the likely sites of infection.
So what kind of samples?
Could be urine. Could be swabs from the cervix in women, urethra in men. Rectal swabs, throat swabs too, depending on sexual history and potential exposure sites.
And what tests do they run on these samples?
The gold standard, the best we've got, are nucleic acid amplification tests.
No dates. No dates.
Yeah, they're super sensitive and specific because they detect the actual genetic material, the DNA or RNA of the bacteria.
Ah, clever.
It's usually best to wait about 2 weeks after potential exposure before testing, just to make sure there's enough bacteria to detect if the infection is present. Think NAPS. News about a tiny thing finding that bacterial nucleic acid.
News about a tiny thing. Okay, now what about screening? There's a national program in England.
Yes, the National Chlamydia Screening Program. It specifically targets 15 to 24-year-olds because, well, that's where the rates are highest. But local areas often have their own guidelines, too.
So who generally gets offered a test?
Definitely anyone with symptoms, sexual partners of confirmed cases, people under 25 are generally recommended for screening, anyone reporting multiple partners recently, and other criteria based on local need.
And ideally, how should testing be offered?
Ideally, it should feel normal, routine, be free, no-cost barrier, painless, obviously, and crucially lead to easy, straightforward treatment if it comes back positive.
Makes perfect sense. Okay, so a positive test comes back, diagnosis confirmed. What's the management plan?
Good news here is chlamydia is very treatable. Antibiotics are the mainstay.
Which ones typically?
Common first-line choices are doxycycline or azithromycin.
Okay.
And this is vital. You have to treat the sexual partners too, otherwise the person just gets reinfected and it keeps spreading. Partner notification is key.
And taking the full course of antibiotics.
Absolutely essential. Even if you feel better after a day or two, you must finish the whole course to properly eradicate the infection.
Prevention is obviously part of management too.
Huge part. Safer sex practices, using condoms consistently and correctly for vaginal, anal, and oral sex. That's the best prevention. And regular screening and testing, especially for young people and those at higher risk, helps catch it early.
Can you give us the specifics on those antibiotic regimens?
Sure. Doxycycline is often preferred now, usually 100 milligrams twice a day for 7 days. Azithromycin is an alternative, often given as a single 1-gram dose, which can be good for compliance, though some guidelines add a couple more days of 500 milligrams.
And what about during pregnancy?
Means careful discussion. Options like azithromycin, erythromycin, or amoxicillin might be used, weighing up risks and benefits for mother and baby. Doxycycline is generally avoided in later pregnancy.
What happens after diagnosis and starting treatment, the follow-up?
Partner notification, as we said. Track down contacts from when symptoms started or maybe the last 6 months if asymptomatic. They need testing and treatment.
Do you always wait for their test results?
Not always. Sometimes, especially if follow-up is uncertain, contacts might be treated preemptively or epidemiologically before results are back, just to cut down transmission risk.
Sensible.
Yeah.
What else is involved in follow-up?
Reinforcing health education, checking they took the meds properly. Sometimes repeat testing is needed, like a test of cure, especially in pregnancy, and making sure partner notification actually happened.
Any other important bits for management?
Yeah, always consider testing for other STIs, including HIV, when you find one. Be mindful of safeguarding issues if relevant. And don't hesitate to refer to a specialist GUM clinic for complex cases or uncertainty. And yeah, always check your local guidelines for specific protocols.
Okay. So, treat effectively, what's the long-term outlook? And conversely, what are the risks if it's missed? Prognosis and complications.
Prognosis is generally really good if treated promptly. Antibiotics work well, like 95% cure rate.
That's reassuring.
But if it's left untreated, that's where the serious problems start. In women, the big one is PID, which can lead to chronic pain, higher risk of ectopic pregnancy, and infertility.
And in men?
Untreated chlamydia can cause epididymitis, which can also, though less commonly than PID causes infertility, sometimes affect fertility.
And specific risks during pregnancy if it's not treated.
Yes. Increased risk of preterm birth, low birth weight babies can cause premature rupture of the membranes, and the baby can get infected during delivery, the conjunctivitis or pneumonia we mentioned earlier. Mnemonic for pregnancy risks could be preterm pregnancy issues, newborn infection, PPI-NI.
PPI-NI. Got it. Really highlights why catching it is so important. How do we prevent these complications?
It comes back to the basics, promoting safer sex, encouraging people to get checked out early if they have concerns, supporting and using screening programs, especially for young adults.
And treating partners.
Crucial. Prompt, effective treatment for the individual and their partners stops the cycle and prevents complications down the line. There's research into a vaccine, but nothing available yet, And, screening programs are only as good as their uptake and implementation.
Right. So, quick summary of our deep dive then. Chlamydia. Super common, often totally silent, but thankfully highly treatable with simple antibiotics. But ignoring it or not knowing you have it can lead to some really significant, potentially life-altering health problems, especially around fertility for both men and women.
Absolutely.
So regular testing, especially if you're under 25 or have changed partners, and always practicing safer sex. These are just non-negotiable, really vital steps.
Couldn't put it better.
And considering how common and, well, sneaky chlamydia can be, it really does make you think, how can we all, contribute to better sexual health awareness and prevention in our own communities? Something to ponder.
Definitely food for thought. And look, if you want more detailed info, more revision resources on chlamydia and other key MSRA topics, do check out passmsra.com.
Great resource.
And there's also loads of valuable free learning material over at freemsra.com. Well worth a look.